How's everyone feeling? Doing okay?
Doing okay.
Okay. We're going to try and keep the energy up because I know it's later on in the day. Sorry I couldn't be here this morning. I ended up having to go to the OR, but glad I got to meet all of you last night. And hopefully this would be something that will be helpful as you get prepared for sub-Is. So again, my name is Chantal. I'm a second year urology fellow here. I'm very, very sad to be leaving next month. I very much love anything that's related to education. So my fellowship is in neurourology and pelvic reconstructive surgery, as I mentioned yesterday, and then I just completed a master's in health professions education. The focus of my master's was on professional identity formation, so you're going to hear a lot about that during the course of this talk, and organizational leadership. So this talk I entitled Navigating the Hidden Curriculum, Success in the Urology Sub-Internship, and I started to put together notes when I was a third-year medical student, and I was asked to give a talk as a fourth-year medical student to the third years, and then as an intern to kind of students along the way. And I've given various versions of it, but essentially the things I wish I had known when I was a third-year student that nobody told me, and if they told me, I would do, and everyone would be happy. So you might recognize a lot of the stuff that come up because a lot of it is very practical applications. Now, what is the hidden curriculum? So in education theory, the hidden curriculum refers to unintended lessons, values, and beliefs that students learn in educational settings. And this extends beyond the formal curriculum. So it has to do with a variety of social, cultural, and organizational influences. And you might ask yourself, well, why should I care about that? I'm interested in urology. I'm going to learn the technical aspects of the field. However, you'll quickly find that the better you're able to navigate the politics and the social, political aspects of your space, the more success you will have. So I intend to talk to you about the hidden curriculum, navigating clinical settings. We're going to talk about the OR, about rounds, about clinic, and then also your sub-internship presentation, expectations and feedback. So there's a lot of stuff that's packed into it. I'm going to go pretty fast. I apologize in advance. And then hopefully we can do questions at the end or grab me afterwards. I'm going to be here tomorrow as well. I just want to make sure you have time for that stuff as well. Okay. All right. So what are some of the sources of the hidden curriculum that we all experience navigating the academic medicine? So you think about your physical space, for instance. So this morning you joined us for grand rounds. Who sits where during grand rounds? That's something that maybe nobody will mention to you, but has implications as to how you're perceived. And then how the admissions process actually works and its alignment with organizational values and missions. So here you can think about things like standardized test scores, how they are valued, time taken away from medical education. So you had to take some time off for whatever reason, how's that going to be perceived? And no one actually says anything concrete about these kinds of things. How faculty treat students. There's some places where students are supposed to be seen and not heard. But you may not know that because you might come from a place where we're all one team, we're all kind of in it, roll up your sleeves, all in it together. The way people behave around different members of the team. So I think a big thing here is what the tone of the operating room that is set by the attending. Does the room go quiet when the attending comes in, or is there a camaraderie that can be perceived, but again, no one talks about physical gestures? I'm not sure why this one makes the slide, but it's there. Peer groupings. So here, over familiarity with residents and attending. So maybe you're having a great day, you think you're vibing, and then you just forget who you're with, and you start sharing things that you probably wouldn't share otherwise. The stories we tell each other about the space of urology. So avoiding gossip, small talk, people talking about other people in the department who are not there. Try and quickly exit stage left when that kind of thing is happening. What is required in the curriculum versus what is elective. So sometimes it's a little murky as to what the expectations are. They might say things like, oh, it's nice when the sub-Is go see consults. Do they want you to see the consult? Is it just nice, or are they going to include that in the evaluation at the end? They oftentimes not clarity around things like that. What is said at orientation about balance and what actually happens? I attended the ACGME conference last year, and there was a very interesting presentation about wellness in residency. And the example that was used was a wellness pizza party. And the resident was like, I don't want pizza. I want to just have some time to sleep. And so if you want to give me wellness, like don't give me pizza. So like, what is the narrative about wellness that you hear, and what is the actual reality? And like, are you even allowed to ask questions about it, or is that taboo? Peers and related corridor conversations, I think I've already kind of alluded to this, particularly avoiding talking about anyone who's not in the room. Here's like a do as I say, not as I do. So there might be like things that are the formal expectations or formal rules, and people are like, oh no, like we can just like go underneath this rope and get over here. Just paying attention to that kind of thing. Black humor, avoid if possible. Who has power, particularly the people that you don't expect to have power in spaces. So there are a lot of unexpected gatekeepers in medicine. So you're in the OR, during this case, there's a nurse who's been there for 17 years. She was there when the attending was a resident or a sub-I and like has their ear. And you may not know that. And you may think that you are the medical student, you made it, you've arrived, they're the nurse. Beware of power hierarchies and dynamics. Just assume that you're going, not assume, try and treat everyone with dignity and respect, regardless of ranking, particularly when you think no one's watching. What is actually being assessed versus what learners are told is formally assessed, and that's kind of something that I mentioned. But things like, and I think that Susanna mentioned this, like, are you actually being evaluated by suturing, or is the expectation that you're going to learn it when you get to residency? Sometimes it's unclear. Stereotyping of people, particularly people who are vulnerable or are considered under the vulnerable population headers. So you think about your unhoused, your immigrant, and minoritized patients, what kind of language is used around them, and how things are said versus what is actually said. So, you know, even with change in intonation, different things are communicated. So if someone says to you, what is it? Is very different than, oh, what is it, right? So paying attention to these unspoken cues. Now, about 4 years ago, I had the opportunity to survey all the urology program directors in the country, and the response rate was 69%. And so good number of programs responded. But what I want to draw your attention to here, what the question that was asked were that the various factors were ranked by program directors in terms of the importance of those factors in ranking the applicants. So at this point, they've interviewed applicants, and the question I was asking them is, after you've interviewed people and you're evaluating them, how do you rank them, and how important are these factors? And what you should pay attention to here is the top close to 10 factors all have to do with interpersonal variables. Your interactions with house staff, interactions with faculty, the interpersonal skills. Like, are you someone that, you hear this a lot, are you someone that they could be doing a long case with and be okay with? Let's see, letters of recommendation. Again, part of that is subjective, particularly because oftentimes you never see that letter. Professionalism and ethics, like there's some degree of ambiguity. What does that actually mean? Leadership qualities, some of that is subjective. So by and large, the things that you're most likely to be ranked by are things that are the softer skills. And this is why paying attention to that is very important. Now, I think that if you start to zone out at any point in time, the one thing I want you to pay attention to is, I'm trying to see if I can move this up the top, is more. And then this one. Yeah. Okay. No, that didn't work. I'll just read it to you. So if you're going to zone out any point in time, I would like for you to just remember this, like what was supposed to be there. Teamwork makes the dream work. And what I mean by that is every member of the team, every member who is a person who's involved in the patient's care is valuable. And the quicker you can like start to appreciate that, the better your experience will be. And this requires a recognition of the multidisciplinary nature of medicine. You've got your scrub tech, your OR nurse, the medical student, the intern, all the residents in between, the fellow, the attending, and think of it as all of us are here to take care of the patient. Now, oftentimes we will have students who come in rotation, they're on surgery, so they don't talk to anybody else in the operating room. They don't talk to anesthesia because I'm not on anesthesia. They don't talk to the nurses or the scrub tech, and then vice versa. You might have someone who's on anesthesia and they're only on the other side of the curtain. You never hear their name, like chatting away. If there is an emergency and you need to refer to someone by name in order to move things quickly, that's not the time to start doing introductions. So when you get into you get into the operating room, make sure that you've taken a few moments to introduce yourself by name to everyone and try and get the names of everyone in return. I'm terrible with names, so I keep an index card in my breast pocket in my scrubs, and I write down everyone's name. I say it multiple times till I get it right. And I think I've told all of you this. I have the memory of a fish. I'm really bad with names, but try your best and figure out how you're going to be able to remember. Continue with simple unrecognized acts of kindness daily. They add up. And I think particularly when no one is watching, and it's the simple things, greeting people and listening to a response. It might seem like, oh, that's like, why would I do that? I'm so busy. Everyone's busy, but we all have time for kindness. Refer to people by name. I already mentioned that. And then this is a small thing, like, moving around, taking the OR bed, it doesn't kill you to open the door for the person who's right behind you. Not that busy, you can't wait 2 seconds. Say thank you. No one's here because of you. And so if someone takes the time to go get your gloves for you, or you asked for something and they showed you where to find the supply closet, say thank you. And you would be surprised. The reason why these things are on site is because people haven't done them. And then involve all members of the team. And I think like a particularly good example of this, and this is something I did every single day of intern year, I called all the nurses for all our patients after I got the plans from the chief, so that they were aware of what the plan was. It made my life so much easier, because whenever the patient asked the nurse questions, they could answer because they knew what the plan was. But oftentimes, like, you get the plan and then you all go off to the OR, to clinic, and the nurses are trying to figure out what's going on. They're waiting for you to drop your note, but you're busy, the note doesn't go in. And so then they start paging you if you're the sub-I or the intern. So get into the habit of communicating with the nurses. You can figure out what that communication looks like. But for me, when I came in the morning to make the list back then, we would actually handwrite all our numbers. I would call all the overnight nurses to figure out like any updates. And oftentimes, if it's a urology floor, one nurse is covering a number of patients, and get a very quick and dirty, did anything happen with my patients? Like, this person has some illnesses, this person was quiet, this, that, and the other. And it gave me valuable information that sometimes was particularly helpful. So now going back to the operating room, because that's kind of what most of your time is centered around, meet the patient before the OR. Don't wait till the patient is in a room surrounded by 7 strangers, half naked, it's cold, they've never had surgery, they're terrified. That's not the time to say, hello, Mr. Smith, my name is so-and-so, I'm a medical student. Meet them in the pre-op area. I would suggest to you to ask one thing or discuss one brief thing about them that has nothing to do with the surgery. So if you get to the room and they're nervous, you have something to distract them with. Most of our patients are elderly, so they might have a graduation, childbirth, a trip coming up, retirement, something that would allow for you to chit chat while anesthesia is doing their thing to calm them down before they're put to sleep. And then similarly, meet the OR team before the patient is brought to the room. When the patient's bed comes in, all eyes are on patient. Sort of like we say this a lot to patients, like a pit crew. Not the time for you to be like stopping the nurse as they're doing their thing to say, hi, I'm so-and-so. Oftentimes they get very short with you if you try and interrupt their task to introduce yourself. So go ahead of time. And when you do go ahead of time, one of the things that comes up is like, what is the glove etiquette? I've seen students come up to the nurse and they're like, oh, I'm a size 7. And I've heard nurses say things like, I don't care what size you are, you're not the surgeon, right? And then I've seen students be like, oh, I don't want to upset them. I'm going to grab my gloves and quietly sneak around the corner and drop it on the table. And I've seen scrub techs freak out, don't mess up my table, you've just contaminated my table. So what I do, and I still do this till today, is I go get my own gloves, I bring it over, and I ask if it's okay for me to open my gloves. So I've shown that I'm willing to do it if it's okay with you. I'm respecting that this is your territory. And then you know that you've kind of got into their good graces when they start grabbing your gloves for you. Like, you do the first case, they like you enough, and they're like, oh, don't worry, I already got your gloves for the second case. You're like, okay, we're making some progress. So that would be something I would recommend. Avoid using the OR computer. So there usually are two computers in the room, one for nursing, one for the surgical team. And now you come in and like you're excited about the case, no one's in there yet, and now you're like, I don't know, looking up your email or looking up cases for clinic for the next day. Your resident comes in, your resident has to staff their patients that they rounded on. They just got a page about a new consult. They're trying to write all their notes from rounds, and now you're on this computer. If the resident is like direct enough and says, hey, I need to use it, then all's good, all's well in the world. But sometimes people don't want to offend, so more passive aggressive about it. And then the next thing you know, like residents are chatting in the call room about how this one medical student was on the computer so they couldn't get their notes done. So don't use the OR computer. There's just two in the room, and whatever you're doing is not as important as whatever it is they're about to do in the morning, particularly in the beginning of the day. So I would say avoid that. The other thing
really quick,
yeah,
just because I would say along the lines of the OR computer, also ask when you go to the resident room, like where the residents sit, and if you can steal a computer, because it's like a big pet peeve for residents. Like you have a limited amount of time in the morning to like review your list, and if the sub-I has all their stuff set up, it's like
you know,
like,
there's a lot of eye rolling that happens. Yeah. Again, the hidden curve.
Nothing against you guys, but it's just like it's not the best way to start off the rotation.
Yeah, but if you come up, typically you'll come earlier and you think you're trying to stay out of the way, so you take the computer in the corner, but that's the computer for the chief or the consult resident, and nobody tells you because they're like they don't want to be that guy. But then they essentially are, because they're going to talk about it the moment you leave, right? So don't be that person. And then one last thing I don't think I have here is write your name on the board when you get to the operating room. The nurses can sometimes get annoyed if you don't, because they have to put down everyone who's in the room, and now you're scrubbed. Your ID is in your breast pocket. They can't see it, and then you're not in the system yet because it's day one, and you're having to figure out who are you, right? So put your name on the board when you come in at the point when you're doing all your introductions. In the morning, first start case. You know, you just started the rotation. You want to figure out this is a residence you want to go to if you fit with the residents. So you want to ask them like why they chose this residency program, where they're coming from, why did they choose urology. 7:30 a.m. is not the time for those questions, people. Because again, like I said, they have to write their notes, they have to staff anyone they saw that morning. They're thinking about the steps of the case. They're thinking about all the things that they should have thought about pre-op about this patient. Did they order the right antibiotics? Do they have all the equipment in the room? And so people don't have the cognitive space to chit chat, especially at the first start. As the day progresses, you know, folks kind of, their sphincter tone kind of relaxes a bit, and then you're able to have more of that conversation. Please try and avoid doing it first start in the morning. It's just too high pressure over time. Help with positioning the patient. So the downside of you coming to do that chit chat is that I'm on the computer, I'm trying to write my notes, and then you're asking me about why I chose urology as my attending. Is like asking me all these questions, things that I forgot to look up this morning. And then the nurse is looking over and being like, is anybody going to help us move this patient? And so now I sigh and I'm like, okay, fine, I guess it's me because the medical student's not going to help. If you go over to help move the patient, you are a member of the surgical team, which means now I have the capacity to write my note, get things situated for patient care. The nurse is happy, I'm ready to do some education. So think of yourself like that, helping patients in the morning, not as like, oh, this is scout work, or I didn't go to medical school to do this, but this is your way to facilitate patient care in order for you to facilitate your education. So helping position the patient before and after surgery. The after surgery, I think sometimes people forget because, oh my goodness, I just did an 8-hour case. I'm so exhausted. I'm hungry. I need to pee. I take off my gown. I let out a sigh of relief and I sit down and pop in a chair. The bed needs to come in. The patient needs to be cleaned and moved back into the other bed. So think about the dance of the operating room and how are you helping facilitate that? So to that end, anticipate, don't duplicate. Someone's already doing something. This is how web students oftentimes will tell me, oh, I don't want to be in the way, and I just want to be helpful. So, you know, you see that the nurse is going to go get the bed, and all of a sudden that's the one task you want to do when there are 5 other things that need to get done. If someone's already doing it, what is the next thing that would need to happen? The patient comes in, the room is cold, we're going to need some warm blankets. We're going to need to put the SCDs on. And the SCDs, if you touch the SCDs, I don't care if it's the chief of surgery who's putting on the other one, look to make sure it's turned on. Because what happens is I do one side, you do one side, you know, teamwork, nobody looks. And then the whole case, the thing has been off. So if you touch it, make it your responsibility to just take a look and see if somebody turned it on. Okay. Practice suturing beforehand. So, you know, this one is tough because depending on whether or not you have like some surgery structure around education, you may or may not have had your medical school teach you how to suture. But you don't want a situation where the first time you do some of the basic types of sutures is in the operating room, right? So know that's different types of closures that you might be asked to do, subcuticular running or a U-stitch or horizontal mattress or vertical mattress. Like, know those names, know generally what it means when someone's asking you to do that, and practice at home on something. So I used Pick Feet. It was $2 from the butchers, and I would freeze it. When I wanted to practice, if I had a block of time, I would take it out in the morning, put it in the fridge, and I would practice for a couple hours. Get some suture, get some like kits from the ED, and that will help you get some needle drivers that way, and practice at home. Don't let the first time that you do like an Aberdeen stitch be in the operating room. Please do it at home beforehand. And then in the case, I think it's very rare that anyone expects that you know the steps of the surgery. If someone expects that of you, one, I think that's too lofty of an expectation. But there have been students who know exactly every step ahead of time. In my mind, that's what residency is for. But you need to know the anatomy. You need to know your patient. You need to know the indications for that surgery. So I'll much rather somebody rolls in 10 minutes late and knows all of this stuff than someone comes in on time and it's like, oh, what surgery are we doing? Or why are we doing this surgery? Because it means that you've not respected the patient enough to prepare to be there. And if you're not prepared, you shouldn't touch the patient, right? So make sure you know this stuff. What was the workup beforehand? What else could have been offered? Imagine that you saw that patient in clinic and you were counseling. That is stuff that you can learn before you get to the operating room. You don't need to have done the surgery to know how to think about the clinical decision-making beforehand. And then the anatomy. Like if someone's pointing up in the right upper quadrant, they ask you, what are you looking at? You may not know because nobody's body reads the textbook, but you should know, have a sense of what should be in that general vicinity, depending on surgical history. So that's why knowing your patient is important. But you can't tell me like, oh, I'm looking at the urethra when you're looking at, you should know what's in the general, in that general vicinity. It will also help you logic through questions that are asked. And it's someone had asked me, is it okay to say I don't know? It depends. Like if you don't know, like if you're looking in a certain portion of the body and you can't mention a single thing there, I would be concerned because it seems like a lack of preparation as opposed to like a lack of like clinical knowledge, or just kind of being able to understand how to integrate information together. So I think it's problematic if you say you don't know something that you could have looked up. Okay. Be mindful when you ask questions. When there's bleeding, not the time to ask questions. I've seen that happen multiple times. So high intensity moments, like you're doing a partial nephrectomy, you've clamped, and you heard the attending say, turn on the timer. Don't ask about the attending's like high school kid at that point, please. And then when you're learning a new skill, this is for anyone who's learning something new. You can't, there's just like a limited amount of space that your brain can like juggle when you're learning something new. So if like the one time that they allowed you to close skin or, do the cysto, don't chit chat during that moment. You're robbing yourself because that's a time where you really want to be focused on that new skill you're learning. You can ask questions about the skill, but don't ask questions about like maybe the team starts talking about their weekend. That's no time for you to chime in about your weekend plans. Focus on what you're doing because that allows for you to actually integrate the skill that you're learning at that moment. Advocate for your learning. So a good number of you are paying for your education. It's not free. Somebody is paying for it. And so in that regard, there are moments where you have to advocate for your learning or for your ability to be able to get engaged in what's happening. So I think it's okay to ask if it will be okay for you to close one of the ports, for instance, because sometimes when you're silent and you don't ask or don't try and like get in there might be the misinterpretation that you're not interested or you seem disinterested or not involved. So it's okay to like push within reason in terms of advocating for you to be able to learn skills. That's why you're here. And then I said this before, I'm going to say it again, especially with after the surgery, help with positioning the patient after surgery. Happens all the time. And we get it. You're tired, you're hungry, you need to pee, but everybody else is in that situation too. And the quicker we get the patient out, the quicker you can all get some rest. Not the time to kind of chill out. Now, in terms of pre-rounding, so you've done the surgery or you're in the operating room, it was you in the breast and you had a great case, never seen a robotic surgery before, now you have. I've had students ask me, do I need to pre-round on this patient? I've heard residents' interpretation of that question being, what do you mean do you have to pre-round once you're in the operating room? And the interpretation underneath that is, you're trying to get out of pre-rounding. So you're asking so that I can tell you that it's okay for you not to pre-round. Oftentimes that you don't have that many patients on your list you're carrying, like patients you actually saw who've been in the hospital. Most I've seen a medical student have like 5 patients who are in-house. And I would assume that you'd want to know how your patients are doing if it was your patient. So if you were in the operating room for a case, whether or not you are going to round with the resident who is going off to see that patient, you can pre-round on patients whose cases you're in. But what does pre-rounding actually mean? In my mind, it's 3 things. Talk to the nurse, see the patient if the culture of the place is such that they're okay with you seeing patients in the morning. And I mention this because there's some places that say, look, we know you're an excited sub-I and you got here at 4 a.m. in the morning. There's no reason for the patient to be awake at 4 a.m. too. So there's some places that don't want you to wake up the patient before the team rounds. And that's a question that you would ask your intern or your residents at the beginning when you're starting off the rotation. But if they're okay with pre-rounding, please see the patient. Look at the chart. So I've had students who, I ask, how much urine output did Miss Jones put out? They look at the list that the intern has toiled to put together, and they're like, Johnny didn't put on the list. Johnny didn't make the list for you. So if you have a patient, look in the EMR yourself to get the numbers for that patient, because many eyes make for things to not to be missed, right? So if Johnny didn't find the number, but you happen to look in the chart, then now you're able to add something of value during rounds because you looked too. Be honest always. So there was a resident, a neurosurgery resident, who actually got 5, and I think he was a chief resident because during rounds he had been asked about patient so and so, and it was, I think it was an omission. It wasn't even a lie. It was just whatever it was. He was not honest, and it turns out the patient died. Very morbid story. I don't have the facts, but the premise, and I know that resident personally, the premise of the story was he had said something or admitted to say something that was an untruth. So don't lie. If you don't know something, much rather get rained for saying you don't know or you didn't look it up, but don't lie, because this is patient's healthcare. Be thorough and meticulous. I've seen interns and medical students who say, oh, no, I got it. I'll remember. There's no way that you're going to remember every single detail about every single person. You also don't need to write a textbook about every single person on rounds, but you need to jot down something. So make sure that you're keeping some record or some way of keeping facts straight, so you're not mixing information. Be thorough, be meticulous. The detailed intern, the detailed medical student is the person that attendings or senior residents that they can trust their patients with, because they're paying attention. Now, ask the intern how they want to be assisted. So when I was an intern, we had to handwrite our list, and I liked my list the way I liked my list. And we sometimes will have sub-Is who wanted to be helpful, who came in before me and rearranged the list how they had done it in their last sub-I in order to be helpful. As you can imagine, I was not pleased as the intern. So you don't want a situation where in an attempt to be helpful, you're actually doing something that is not helpful to the team. So serve people, my husband and I say this all the time to each other, serve people the way they want to be served. And they may not want you to make the list, but they may want you to get supplies for rounds. Right, so ask. Now with rounding, be early always. Traffic is not an excuse. My car broke down is not an excuse. There's Uber, there's Lyft. Like, just be there and be there early. Being there on time is not good enough. Be there early. This is an addition. Every single day you're there is an addition. The best time to ask for supplies for rounds is not in the morning. So, you came in and then you are thinking to yourself, they mentioned something about void trial. In my last rotation, I know that they do void trials with Turks. Where am I going to find like the urinal? And then the intern who's trying to figure out juggle 30 patients, you're now going to ask them where to get a urinal. You can imagine the intern is not going to be pleased to take you to go to the supply closet. However, the best time to ask about supplies, when at the end of the case, the attending has unscrubbed or has left the room, is dictating, your resident is trapped there with you because they have to close. And so they're scrubbed. They can't leave. And you're scrubbed too. And maybe they're letting you close a portal too. That's when you ask, what kinds of things would we need for rounds for this patient? And they might be like, we tend to do void trials. We don't like to carry buckets. So some places want you to carry all the supplies in a bucket and take it around and spread germs. Other places don't want you to do that, but they want you to carry just what you need in your pocket. And so when you ask and they say, okay, we're going to do a void trial, then you might think to yourself, I need an empty 10cc syringe, I might need a urinal, this and the other. The student who actually has precisely what we need during rounds tells me that they're anticipating, they really have an understanding of what this patient's care is versus a student who has a whole suitcase, right? So ask when you're at the end of the case, because that's a great time. Offer a gentle reminder about your presentation. Like, so for places that have large services, they have multiple people to get through, they're trying to get through quickly so they can go consent their patients. Oftentimes people are not thinking about like, oh, what case did you see yesterday, and like who are you presenting on? So again, this is an example for a place that you want to advocate for yourself. So I would say, like, usually you have to walk from point A to point B to ground, right? You start off in like a corner or room or whatever, and you're walking around. As you were leaving your hub where you start off, that might be a good time to be like, oh, I saw Miss Smith and Mr. Jones. Is it okay if I present on those patients? And then as you're walking from the patient prior's room to the patient who you want to present, you might want to give a little reminder there because they may have forgotten again. And so I've seen students who did the right thing. They reminded us as we started to walk, but we have 30 patients and we're just like on the move, and then we forget. And then we see them sulking and we don't know why. They had come in half an hour before everybody else. They had prepped, they were ready, and everyone forgot. So please, like, it's not personal. And sometimes it's just not a good time, but usually it's a we forgot situation, to advocate for yourself. Now, when you do round, so I trained at UCLA. I think I mentioned this yesterday. I was a resident there, and there are like 6 different light switches for the room. Some of them as bright as this, and some of them pretty dim. I oftentimes would turn on the dimmest light possible to be able to do the exam. And I'm a big believer in like giving the patient a heads up. So I'd say a little bit of light coming on. I'll turn the dim light on, and maybe 50% of the time, a medical student will turn the light that looks like this at 6 a.m. And I'm like, there is no reason for it to be this bright. So be mindful of that. If you had just had a surgery, you're very uncomfortable, you're sleeping in a bed that is not your home bed, and somebody came up 5:30 in the morning to do an exam, would you want this light on, right? So those are just like small practical things. When you go into a room, put on gloves and stand on the other side of the person leading the encounter. I've seen students who, like, we all come in as a team, and the person leading the encounter oftentimes will be standing on the right side of the patient's bed and like chatting, trying to get a sense of how the patient's doing. And the students are like kind of like hanging out and just like listening, like learning, no gloves on. No one's gonna wait for you to get ready to help. And oftentimes they won't even ask you to help. Then you'll see, like, if there's a APP or another resident, in their mind, they're like, oh, I guess the student isn't helping. They go put on gloves and they just kind of get into position. And so what I would recommend you do, even if it's not your patient, I mean, every patient on the team is your patient because you're part of the team. But even if there was another student who was in that case, put a pair of gloves on and stand on the other side of it, unless there's another student who is primary and is standing there. But put gloves on, like, you want to be ready. And then once you have your gloves on, grab another pair for the person who's leading the encounter and stand on the other side of the bed. Now, I've had students who, I'm chatting with a patient and the student's like right here on my hip, not helpful for you to be right here. If you're on the other side, you're more likely to be able to help with the exam. And then once the chit chat is like kind of going down, or basically like wrapping up, you have the gloves ready to hand across the bed to the person in the encounter. So you want to think about it this way. You have 2-3 minutes to get into the room, ask the patient how they're doing, be able to develop rapport with the patient, communicate a plan, do the exam. And sometimes, depending on the team, they might also be putting orders on the computer as they go and leave the room, right? So anything you do to distract that binary between the person leading the encounter and the patient is not helpful. So to that end, you really want to think about like just kind of how you're contributing to the dynamic in the room and protecting the dyad between the person in the encounter and the patient themselves. So when you walk into the room, like, what are some of the things you're thinking about looking at? So physical exam, like just looking at the patient is helpful. Is this somebody who seems anxious? Are they diaphoretic? Are they just like looking like they don't eyeball well? So you hear a lot about the eyeball test. And then if they have a monitor, what are you seeing that might be important for a post-surgical patient? Are you looking at the heart rate? Are you looking at their O2 sat? Do they have a nasal cannula on and you know that they don't have a history of using oxygen at home? Their sats are like in the 89, they are on 6 liters. You're like, this just doesn't add up. Pay attention, even if it's not your patient. Now, the abdominal exam, I've seen a couple of things happen. I'm doing an abdominal exam, patient has had a kidney transplant, and I just start to feel, and then the student's like, oh, like ready for the exam. They press 2, the patient says, ouch, and the patient's like, no, I don't want you to touch anymore. Now, I don't know if it's where I pressed or where you pressed. Was it rebound? Was it, on deep palpation? I have no idea. So what I would recommend to you is if the person in the encounter is doing an abdominal exam, don't press at the same time. They will eventually finish. And when they're done, don't do is it okay if I do an exam too? Because now the patient looks at you and they're like, wait, are they not supposed to be here? Like, why are they asking permission? Like, is it like, what's going on here? You've disrupted the dyad. So the person who's doing the exam finishes the exam. As soon as they're done with the abdominal exam, you quickly put your hand. No one's going to be like, don't examine them unless the patient's like remarkably uncomfortable. So that's how I would do that. Other things that you can do on post-op day 2, most places, if they have a dressing that comes off, you can help with that. If they have a JP drain, you can strip it. If they have any drains, pay attention. If they've got an NG tube, what's the nature of the fluid that's in there? Is it on suction? Is it on gravity? If it's on suction, is it continuous or is it intermittent? If they have a JP drain, is the drain, like the tubing, clotted off? Is the JP drain full and no one's emptied it? What's the nature of the fluid? Is it grossly bloody? Is it serous? Pay attention to that. They have a catheter, they're not circumcised. Is the foreskin over the glands, has it been pulled back? This happens a lot with nursing. They cleaning the glands and then they leave it pulled back, and that's a consult for you to come in the middle of the night for paraphimosis. So pay attention to that. And then with the catheter, catheter bag's on the bed. It works by gravity, so make sure it's down. So pay attention to those things. And then my personal favorite is the SCDs. I used to be called the SCD police in residency because what would happen is you place the order, the patient came out with the SCDs, the thing on the leg itself. Now, the patient woke up in the middle of the night, went to the bathroom, so it was not connected. Or the patient actually came back and they connected a great job, but nobody actually plugged in the machine when the patient was brought to the room. Or they plugged in the machine, but they turned it off and they forgot that even though I unplugged it, I had to press like the power button. So for all these reasons, I've had 2 fasciotomies that I saw happen in residency. And I've seen a number of DVTs. We did a lot of kidney transplantation. We also did a lot of genital affirming surgery. So people in high lithotomy, and then also people with just a high risk for thromboembolic events. But just pay attention to the leg. So what I actually appreciated when the medical student did this is after the abdominal exam, as we're wrapping up the encounter, a medical student who quickly took the SCDs off, felt the calves, noted asymmetry, noted if this is the leg cool to touch, is there anything going on there, and then put the SCDs back and turn it on. That was my favorite medical student. That's all they had to do for me to be like, you're the best person in the world. So pay attention to that. I already spoke to you about, another thing I spoke to you about stripping drains. This is a very small thing, but if the JP drain isn't draining, and no one actually told me, I just noticed it at different places, a very easy trick that you can do is put a little bit of alcohol in your gloved hand, your right hand, if you're right-handed. Use your left hand to hold or to pinch the JP drain tubing close to your abdomen. That hand has no alcohol because you don't want that one to slip. It's just to keep things steady. And then with the alcohol hand, just use it to strip the drain so all the gunk in it goes into the tubing. It's a very small thing, but if you don't do it over time, if the patient has a drain for a while, it could get clotted. And if you put the alcohol on both hands, I've seen this happen twice with a student who got overeager. The left hand that was not supposed to have the alcohol and moves and slaps the patient's abdomen, they get really upset. So if you don't understand what I mean, ask me after the session, I'll explain it again. And then have your supplies ready. Again, I'm not a big believer in having a bucket that could serve as a fomite, taking bacteria from place to place, but have the stuff that you need ready in your pocket. And a small act of consideration, this is a big pet peeve of mine, is asking what the patient wants with the light as you leave. We had, again, in these individualized rooms. And so do you want the light on, or would you like us to turn off the light as you walk out? It doesn't take any time away from you, but oftentimes shift change is about to happen around rounds. And then if they're not able to get to the light switch, then they have to stay in that situation. Or maybe they want the light on. Don't assume that they want it off. Maybe it's an early morning person. So that's kind of all the stuff. Oh, actually, sorry, a little bit here. consider if it's appropriate for you to present. So we have a full service, or there's a medical emergency, or like it's time to go consent the patient, unstable patient. You have early morning conference. Don't be offended if you prepared and you can't present. However, presenting is a skill that you really, really need to work on, because that's how you staff consults. That's how you staff when you're in clinic. That's how you present to colleagues when you're trying to get advice about a case. So that's something that you need to do for your learning. Personally, what I offered every medical student was, when I'm driving home, I'm happy to listen to you, for you to call me on my drives, and we can practice your presentations. Other residents may offer this to you, or you can ask if you have downtime, like towards the end of the day, or a resident who's on research or has a live clinic or something, ask if it's okay to practice your presentations in the afternoon, because that's a skill you want to get better at. And doing it just during rounds is not the only format that's possible. Be prepared to present if you're called to do so. So don't be like, oh, I didn't think that I was going to present today because we had conference. See if there's a preferred template. So we use something called the DIAPP model. At UCLA, other places might want you to go by systems, whatever it is they used to, because what you don't want to happen is they have a system that they want to hear, how they want to hear the information. You have a way that you think you want to give the information, and in the middle of it, they're like, no, do it by systems. And then you get flustered, right? So ask when you have your first encounter with a resident or interns. I advise that's before the rotation starts. Ask about how they want things done, and be systematic. So if there's a format, stick to it, practice it, make sure you get good at it. My next thing here, and this probably would be one of the things that I strongly recommend, avoid asking, what can I do to help, or how can I help? Because it puts the residents in a tricky position. I'll speak for myself. Maybe other people don't care. If you asked me, how can I help? Oftentimes I'll be like, oh, it's fine. We got it. No worries. Because I don't know what you know how to do. I don't know what you feel comfortable doing. And I don't want a situation where I need records from the VA. That's what I actually really need before I go scrub. And then you asked me, so I said, can you do it? And you said yes. And then you call your friend being like, you didn't do 3 years of medical student to school to be a secretary, glorified secretary. And then you write me up. Don't want that. Or situation where I'm like, oh, you know what? We need to get the JP drains out. Can you go pull that? And now you're in a situation where you don't know how to do it, and you feel like you can't say you don't know how to do it. So what I would recommend you do is almost always everyone has a list for every patient on the service. Write down everything you hear about every patient. You hear a lot of muttering, or people be like, oh, maybe we should stop the fluids today. Oh, I'm going to talk to Dr. Salami and see if he wants us to pull the JP drain. Just write down everything you're hearing that could be possible plans or to-dos for every single patient. And then what I would recommend you do is that you volunteer for yourself for a task that you actually want to do, that you can do. So I will call radiology and get that read, or micro to see about the urine cultures, or I will pull the JP drain. Maybe you've done it before. So now you've volunteered yourself for a task you want and that you can do. But there are things that you probably want to learn on the rotation. This is an opportunity for you to advocate for yourself. So I actually have this somewhere. So what you would want to do in that situation is say, I don't know how to pull the JP drain, but can I go with, whoever it is that had volunteered themselves to go do it? And then you do it. They see you do. You see one, you do one, and then for the rest of the rotation, you're able to pull the drains. So volunteer yourself for a task. If you do something, circle back and let the team know you've done it, so we can all cross it off our to-do list. So I had a situation where the intern in the middle of the day had planned to go take out 5 JP drains, had all their supplies, had stopped what they're doing to go. And the sub-I had done so wonderful. They had gone and pulled all the drains, but hadn't told anyone. The intern was livid. So even though they had been helped. So circle back, let the team know, because then we can all get a sense of what needs to be done. And I think I've already said all this stuff here. How are we on time? Because I know this is...
We're good. We might want to take a couple questions to get.
Okay.
I will say one of the pet peeves that I hear from the residents is when they get a consult from a med student, and the med student neglects to put things like a callback number because they think it's like texting, and we have no idea who it is.
100%. I see that all the time. Another thing with consults is there's a lot of etiquette with that, and I don't want to spend too much time, but I would say if you are conversing with another team, start with what the reason is that you're calling for before you go into all the details about the patient. So the first thing I want to know when someone calls me is like, what do you need? And then from there, I can kind of frame like what information I need to hear and what I can ask about. But exactly as Dr. Go said, like when you send pages, be very careful, like double check who you're sending the page to. Don't just send the pages to attendings. Like ideally, you know, if it's just I was just telling Julie, so like if you need to know like where you need to go the first day, like email or text is preferable over a page, because to residents, a page means an emergency. Like people at this point in time with my chart communications and everything like that, we don't really get a lot of pages. So if we get pages where they go like, oh my God, we just dropped everything. So definitely like be very wary of sending pages and just be very cautious.
I had a question, Daniel. You had a question, Tony?
Oh, yeah, so it's just back to the social aspect of things that are, and this might be a better question for those who graduated, moving on, but the resources for prepping for cases, whether that was visual, I think, talked about the anatomy and was there any resources that you guys found were most helpful, if you know of any that students have used in the past?
I use a lot of stat rows, like if you just look up the case, like stat rows would give you like basic steps and sort of that. That's more. Yeah.
YouTube, honestly, YouTube walkthroughs of anything that's robotic, especially. There's tons of great cases. And then I know that you guys got the readers pocket urology. It's dense, but for some things like stones and size guidelines and things like that, it was really helpful. And then AUA guidelines are free online. That was super helpful to go through also. And I know that we talked about OR, but also practice for clinic, but using the guidelines is really helpful. If you know that you're working with like Dr. Gupta, she's like PPD, and she does a lot of overactive bladder. You can look at overactive bladder guidelines and say, this is first tier behavioral, this is second tier med, this is third tier big surgeries. And then you see the patients, you're obviously smart if you can say, oh, this patient's now tried all first and second tier, so now we would consider third tier treatment.
I think also think that on that resource that's really good for that. That this might be a hot take, but I think using AI tools, especially nowadays that they've gotten better, on my sub-eyes, I use AI and cross reference with things like 10 minutes, and it was really accurate most of the time. So definitely double check everything it says, but it can be good.
I think it's still used like that was like the big
I've heard.
sounds. But you know, I kind of think readers, it's like great book for interns. It's start with that. You know, the brain jumps in my head if they don't know where it is. I think having some of that, again, 10 minutes is very interesting. So usually the sections are fairly short, we've also that's useful to do that. That's a handles is ridiculous. So
Sorry to interrupt. I was just gonna add, Hinman's has the kind of like overall steps of the case. So I agree, like you definitely don't need to actually know all the steps, and I definitely didn't remember them just from reading it, but it helped me to have some idea of what was going on in the case so I could follow along and just like have enough idea of what's going on that I could get something out of it.
I'm just gonna add to the, or like not to interrupt nurses, like when they're doing sign out to each other, do not walk up to them, they're gonna murder you. And then when we're doing the timeouts in the OR, everyone can stop what they're doing. Don't be fishing stuff out of the closet. You don't know if someone's inspecting us. Sometimes we have fake Jaco, sometimes it's real Jaco, and they catch us touching anything, we're fined. And you could have been the one responsible for it, so you don't wanna do that.
And don't touch the nail stand, especially when you start off. Probably everyone already gets that, but sometimes you're like, you better get those next sutures so there is it.
Yeah, don't reach, cause they have sharp instruments, they will come after you.
Yeah.
I think another important point for when I see this type of case. We don't take the time to learn what you know something exciting. You notice that. And it just makes it less violent and so it's in the less interesting. And the other side of that coin is also the ability of a grant.
those about that are starting to drop in, seeing a little bit too buddy. Actual video, simple, where you're asking questions like a long time, you're asking a question because almost to know the these are things that are lost. So, try to be yourself, but remember these old subjects there.
I'm working. What are kind of like first day expectations for sub-Is? Like, should I reach out beforehand to like see like what's going on and like?
Yeah, I think I have to slide on it. Oh, sorry.
So, I mean, for our sub-I, at least, like, I have you guys meet with me at 8:30 in the morning. And none of the residents expect you to like do anything pretty much that day. It's like getting your whereabouts, getting your ID badge, making sure your badge works. And then like, I literally take them to the resident room and then like, they're like, okay, where do you get scrubs? How do I sign into the EMR? Like different things like that. So, and yeah, every resident will be like, here, we're gonna take it easy today. Like, they're not gonna expect much. You will get a schedule beforehand, but typically they're not supposed to. Like put you on a ton of stuff that first day because unless like you're a Michigan medical student that knows where you are at and all that stuff, so.
It also depends on where you are. So at UCLA, we expected that on day one, you're gonna like get right into things. And so if you had like an OR day, you already signed cases on day one. If you're in clinic with Dr. So-and-so, they would have expected that you'd looked up their clinic patients beforehand. So for my sub-Is, and I did a sub-I at UCLA and I matched at UCLA, so I was there as a resident. I always went the day before my sub-I started. Usually it was a Sunday, quite frankly. And I just walked around the hospital, walked around, tried to figure out, because it was a Sunday, usually a slow day, I never had any issues. I did 4 sub-Is. Figured out like what the general area of like where the cafeteria is, where the OR is. Usually you would have gotten an email ahead of time saying like, we'll meet you on, I think we had it that we would meet the students at 5:45 a.m. Now I think about it, it's so ridiculous, it's that early. And on the 8th floor, like where, like 8th floor, where's the elevator, which building, right? So depending on the place, they might have the expectation that you get in there and you're ready to go. I would get my scrubs the day before, if I had ID access and whatnot. So if I didn't, then I guess I would, figure it out. But not every place has a gentle role in.
That out the EMR before that first day.
We had to do training ahead of time. They sent you everything ahead of time, and so you had access to the EMR
Okay.
before the
I mean,
next
I
day.
think you guys had access, but it was hard to understand it, right?
Oh yeah, it was hard to understand.
Oh, 100.
Yeah.
It doesn't have like a whole course basically that you had to do that grades and.
Yeah.
Okay,
It's not a real grade, but it helped you make sure.
okay.
Right. Should I keep going or questions for? 5 minutes. 5 minutes. Okay. I never finished this thing. All right. So very quickly, navigating clinic, notes to review. So I would say some places they allow you to see patients on your own in clinic and then you staff with someone. Look at the last few urology notes because the person who wrote the note before, if you're like, you're just gonna look at someone who stuff. So I usually look at the last 2 to 3 to get a sense. Particularly if it's a shared patient pool and not the same attending. And then I look at the last PCP notes to see if there's any like new health stuff, particularly diabetes, hypertension, if they've had any recent like surgeries, that kind of stuff will be in there. Recent specialty and emergency department notes, if they've been to the ED. So for instance, you look at the PCP note, the urology note, and you staffed, but then they were just in the ED for urinary retention after they saw the PCP and the urologist, so you I always take a quick peek. I don't read the whole thing. Just like what were they there for as a relevance to a visit. The last urology op note, if a post-op patient, it might sound like a very like basic thing to do. Look at the op note, look at the findings at the very least. Look at the pathology if it was they sent something to pathology. And then when you're reviewing history, this is like basic, med school stuff. I would strongly recommend you look at everything I have there, like what medications are they on that may or may not be related, labs, imaging. And I always do in the same order so I don't forget anything. I think I already mentioned that so for clinic notes, see if they have preferred templates. Sometimes the institution, everyone uses the same template. Some attendings are very particular about templates. Very recently, we had a student who came in very helpful. They had pre-charted for everyone and had drafted notes, but it was all with a template that the attending didn't want. we had to redo all the notes. And the student had spent so much time, so could have been avoided, simple question. And then physical exam. So I've seen students who have gone ahead and done a DRE or a vaginal exam and really freaked everyone out by doing that on day one. So ask and see what they want you to do for sensitive exams. This is urology. And then chaperone policy. So here you have to do with the chaperone. And then at UCLA towards the middle of my residency, they introduced that as well. And then ask if they want you to do it with or without them. Sometimes they're okay with you doing it, but oftentimes not. And then sub-I presentations, I'm just going to try and run through this very quickly. Sometimes you're lucky and you're assigned a faculty or senior resident. If you're not, try and find somebody to buddy with to help review your presentation ahead of time, or to talk to them about the topic. Content expectations. Sometimes they expect you're presenting your research. Excuse me, sometimes they want you to present a case that you saw during the sub-I. That was a very big thing for UCLA. You cannot present anything but something you saw during the sub-I. So you had to find something interesting early enough so you could present it. Sometimes they wanted you to present an area of interest of your assigned faculty. That was true for me at Yale. I did my sub-I there. And then sometimes you want to make sure that you're not presenting something that someone presented the last sub-I block, or they just had grand rounds on 2 weeks ago. So maybe you saw something really cool and interesting, but they recently heard about it. And then they may want you to use the PowerPoint template from your medical school, or they may want you to use it from the one for the institution itself. Just ask. I've seen people like pass comments as a silly thing to nitpick, but people do. And then how much time do you have? Clearly, I'm not respecting that, but please respect that when you have your presentation. And some places want you to have personalized slide. Michigan, for instance, they always start with this is who I am, these some pictures, my dog and my family and whatnot. They did not want that at UCLA. So find out what the expectation is. And then a thank you slide. All of us are here because of the investment of many other individuals. And I think it's really important that you have a thank you slide that acknowledges the people who have contributed to you being here. So it could be research mentors or your career mentors, whoever. I tend to use headshots of those individuals to acknowledge that I'm here as by virtue of those individuals. You can use names, but don't have no one. I heard during a rank meeting that someone was ranked lower because they felt that the person didn't acknowledge the folks that had contributed to success. So prepare, practice. I'm sorry, no, like this stuff, like all of this is informed by things that have actually happened. Resident perspective, so you want to be able to figure out the politics of the place. So there's some viewpoints that may not be acceptable here. Everyone does whole-ups, but at UCLA, they're like, why would you do a whole-up? Why would you do a term? So find out what the politics of the place is. If you have an attending, just kind of get a sense of what the area of expertise is, or if there's someone who is an expert in what you're about to talk about, please talk to them ahead of time. You don't want to find they have an opposing view that on the day of the presentation, because that will be very uncomfortable for you. Your goal is you want them to spark conversation. Ideally, that does not include you. So you want them to be bantering, you want them to have questions for each other, and then you want to be one of the experts in the room, but oftentimes you're not, and that's okay. But a great sign of a good talk is when they're going back and forth. If you didn't actually have to answer anything, but they're going back and forth, they leave it being like, oh, that was such a great talk, because they got to say something too. So if you're able to figure out what that is for them, that would be good. And then lastly, this should be 2 minutes here. Expectations and feedback. Don't wait to be surprised by feedback at the end. I did this for every rotation where 1/3 of my time through, we had 3-month blocks. So after a month, I would ask to check in to get a sense of if there's any feedback. So before you start, you want to know expectations. And then once you have a sense of expectations, before you get to halfway, I would recommend getting a sense of things that you can work on and change. And I have some targeted questions to help you with that. You want to schedule ahead of time. If we're walking to the cafeteria after a long case, and you're like, oh, do you have any feedback for me? I'm hungry. I'll just be like, no, everything is good. Everything's great. Just keep doing what you're doing. You want to ahead of time. If you told me oh, can we chat tomorrow in the afternoon about how things are going briefly, then I'll think about it in the evening and then have something to tell you that's concrete. And then you want to ask for feedback at the end to make sure that you've had an interval change if they gave you some stuff to change. So how to prepare for those sessions. What have you learned? You should have answers to these questions for yourself. And just in case they ask you, what have you learned? What do you think you did well? You don't want to say that you don't think you did anything well. So have some insight.